topics like the causes for gradual loss of vision, right? We'll be discussing about the primary open angle glaucoma, acute primary angle closure glaucoma. We will be discussing about the mechanism of these primary and secondary angle closure glaucomas. We'll be discussing ophthalmos, acute congestive glaucoma, pseudoexfoliation syndrome, aqueous humor formation, and the uses of mitomycin C. So these are a topic of discussion. And this topic, that is glaucoma, it is very important and has been frequently asked in a previous year questions. Okay, so before starting for today's lecture, let me give you a brief introduction of what is Auricle. So here at Auricle, we have recorded classes, live classes, practical sessions, rapid exam modules, and the hard copy book set. So these recorded classes gives you the flexible learning, and it offers you to and it offers the freedom to choose from multiple educators of each subject, and it comes with 10 years of experience, and it is made keeping in mind your MBBS Proff exam as well as your competitive exams. So you can watch these videos at your convenience, at your time, whenever you feel watching those videos and learning. And it also helps you to conveniently revise your syllabus at the last moment. We also have live classes like this. So live classes covers your topics in in-depth coverage, and it is taken up by the expert educators, and it also provides you with interactive learning. It allows you to participate in live doubt clearance and to participate in MCQ polls, to participate in Viva questions. Okay, and this lecture also covers your important past 10 years previous year questions and the most anticipated questions that could come in the exam this year. And it also gives you the way to frame your answer and how to write your answers. Okay. And we also have express exam module, so rapid exam module. It is made to cover your entire syllabus in under 20 hours. And it also gives you tips for your answer writing skills. And this is also a very interactive session which focuses on mainly exam strategies. And it is taken up by the expert educators, and it will cover your entire syllabus in under 20 hours. Okay. Apart from this, we also have our one-to-one doubt clearing session where we clear doubts with the respective educators, and you can excel in your exams like this. And you can always ask questions whenever you have any doubt. Okay. This helps us to create a very student-centric approach, and personalized attention is given to every student for creating a safe learning environment. Okay. We have hard copy book set. These notes are made in a very crisp and concise manner so that you don't need to read every line of your textbooks, which is a very cumbersome process. Okay, so these notes are made to conveniently revise and to effectively learn all the important points, okay, so that you don't forget the key points or the main headings that you need to write in your exams. Okay. So these notes are very colorful, okay, and written in a very point-wise and in very crisp and concise manner, only important topics that is required for your exams. Okay, we have question banks also. So these question banks is very essential for you to practice before appearing for any exams, because practicing questions is must to judge yourself or to examine yourself how much have you read or how much have you read correctly. Okay, so it covers the MCQs for your Proff exams, for your NEET PG exam, and also for your FMG exams. Okay, last but not the least, we also have our practical sessions. These Auricle practical classes provides you hands-on experience and in-depth coverage, in-depth understanding of MBBS practicals, and it also tell you how to give your Viva answers. And these practical sessions will be helpful for you to gain the confidence and skill which is required very much in your practical sessions. Okay, so these practical sessions must not be missed by you, because these practical exams carry as much marks as your theory exams. Okay, so this is very important session. These are very important sessions, and you should not miss it. Okay, so we have 4 kinds of subscription plan here at Auricle. We have foundation plan, advanced learning plan, complete learning plan, and ultimate MBBS plans. These plans vary according to their duration of their validity. So foundation plan is for 3 months, advanced learning plan is for 6 months, and this complete learning plan for 12 months, and the ultimate MBBS plan is for 4 years. That is throughout your MBBS journey. Okay, so you can opt for any plan according to your need. Okay, so if you opt for the ultimate MBBS plan, you will get access to everything for all the 4 years. Okay, so let us start today's topic, that is glaucoma. Okay, so we have heard about glaucoma. Yeah, it is not that we are listening this word for the first time. We have come through this word many times in our previous live sessions. Okay, so glaucoma is one term that is very common. Okay, you must have heard of. And the glaucoma, I have told you whenever we came across this word, I've always told you that it is the increase in intraocular pressure. So glaucoma means nothing but the increase in intraocular pressure. The meaning of this term glaucoma, or the definition of this term, is the increase in the intraocular pressure. So we are going to discuss about the glaucoma, the types of glaucoma, the clinical features, the fundus sign, the management, the diagnosis, right? So we are going to discuss about these topics. So first, we're going to discuss about what are the causes of the gradual loss of vision. Okay, so this is a very common question, and you can get this question, gradual loss of vision, like what are the causes, enumerate the causes of gradual loss of vision. You can get this question as a pre-question for anything. Okay, like for anything, like what is conjunctivitis, what is myopia, what is hypermetropia, what are refractive errors. So whatever the question is, the long answer question. Okay, whatever the question is, the first question can be enumerate the causes of gradual loss of vision. So you should know what are the causes of gradual loss of vision. It is not related to glaucoma only. It is related to vast number of things in ophthalmology. Okay, so we are going to discuss about the common causes. So the first most common cause is the primary open angle glaucoma, or the you can simply say the open angle glaucoma. Okay, so glaucoma can lead to the gradual loss of vision. Second, cataract. Okay, third, age-related macular degeneration. We'll be discussing about this in our subsequent coming live classes. Okay, diabetic retinopathy, retinitis pigmentosa, optic atrophy, refractive errors, and chronic uveitis. So these are the 8 most common causes for the gradual loss of vision. Okay, now how do you remember this? Okay, so first of all, glaucoma. Remember glaucoma, cataract. Okay, these are the 2 most important causes. Glaucoma, cataract. Now in glaucoma, which type of glaucoma? Primary open angle glaucoma, POAG, primary open angle glaucoma, and the cataract, which type of cataract? Senile, traumatic, and congenital. Okay, senile, traumatic, and congenital. These are the 3 types of cataract that causes the gradual loss of vision. And third, you can have age-related macular degeneration. You can have them diabetic retinopathy, retinitis pigmentosa, optic atrophy, refractive errors if uncorrected. Only if they are uncorrected, right? And you can also have chronic uveitis. So these are the 8 most common causes for the gradual loss of vision, and it can cause your vision to be permanently impaired. Okay, so just remember this in the sets of 2. Glaucoma, cataract, age-related macular degeneration. Remember this as separate thing. Okay, diabetic retinopathy, you can remember it as DR, doctor, Okay, retinitis pigmentosa is RP. Okay, RP stands for regular practitioner. Okay, regular practitioner, RP, retinitis pigmentosa, doctor, DR, diabetic retinopathy, right? Then optic atrophy, refractive errors, and then chronic uveitis. Just remember it like this, then I think it would be easy for you to remember this. Okay, glaucoma, cataract, ARMD, or age-related macular degeneration, diabetic retinopathy or retinitis pigmentosa. Okay, a doctor, regular practitioner in the short, or you can consider it as a mnemonic, and then optic atrophy and refractive errors. Okay, and at last, chronic uveitis. So these are the causes for the causes of gradual loss of vision. Okay, now discussing our main topic, that is primary open angle glaucoma. So what is the etiology of primary open angle glaucoma? So first of all, I want you all to focus on the diagram given on the right hand side. Okay, now this diagram, it is showing cornea, trabecular meshwork. Okay, open angle, this is open angle. Okay, now this is iris, and this is ciliary body. Okay, this is ciliary body. This complete is a ciliary body. The pink color is complete ciliary body, and this is the iris, and this is the zonules. I told you zonules hold the lens. Okay, these are the zonules. Okay, so we have cornea, trabecular meshwork, open angle, ciliary body, iris. Now you can see this is the open angle, the angle this form. Just focus on my red marker. Okay, like this is forming an angle. This cornea and this trabecular meshwork and this iris. These three things: cornea, trabecular meshwork, and iris. These three things are forming an angle, and this is known as open angle. Now we'll see what happens with this open angle. Okay. Now, first of all, we'll discuss the etiology of the primary open angle glaucoma. Etiology, you will have multifactorial condition. Okay, it is not like that only one factor is responsible for causing open angle glaucoma. Multiple factors are responsible for causing this disease. Okay. Obstruction of aqueous humor drainage through the trabecular meshwork. Okay. Now, this complete part, this complete part is filled with the aqueous humor. We all know that. Okay. This complete part is filled with the aqueous humor, and the posterior to the lens is filled with vitreous humor. So we have two types of humor, aqueous humor and vitreous humor. Okay. So this is the aqueous humor. Okay. And this aqueous humor is continuously drained by this trabecular meshwork. Okay, continuously drained by this trabecular meshwork. If there is obstruction of aqueous humor drainage to this trabecular meshwork, okay, if there's obstruction to this meshwork, then what will happen? The aqueous humor will continuously be built up over this space, over the anterior part of the lens, between the cornea and the lens. The aqueous humor will be completely filled up, and aqueous humor is continuously being producing. Okay, it is continuously been made up. So what will happen? There will be result of piling up of the aqueous humor. And if the aqueous humor gets continuously filled up, so what will happen? The pressure will increase. The pressure in this compartment will increase. The pressure in this compartment will increase, right? And if the pressure will increase, it will result in the increase in IOP. The third point, just see the third point over here. Elevated IOP. Okay, intraocular pressure will increase. So that results in the primary open angle glaucoma. Okay. And fourth is a hereditary predisposition. If your parents or your grandparents have a history of glaucoma, then also you can be predisposed to this condition, and you can have glaucoma in your later stages of life. Okay, so what have we studied? We have studied about the multifactorial condition. It is a multifactorial condition, and there can be obstruction of aqueous humor drainage to the trabecular meshwork. So just remember this term, trabecular meshwork. It's very important, right? Trabecular meshwork is very important. And due to this, there can be filling up of aqueous humor continuously, and this continuously filling up of aqueous humor in the anterior chamber. Okay, in the anterior chamber, it can lead to the elevated IOP. Now, this elevated IOP is responsible for producing glaucoma. Is glaucoma, right? Okay. Now, the risk factors. What are the risk factors? So the risk factors include, first, age, greater than 40 years. They can be family history, African or Asian ethnicity, myopia, and hypertension, diabetes, or steroid use. These are the comorbidities. Okay. So the risk factors includes age greater than 40 years. If you have a family history of glaucoma, if you are African or Asian by your ethnicity, if you have myopia predisposes to primary open angle glaucoma. And if you have hypertension, diabetes, or steroid use for any of the diseases, if you're taking continuous steroids, then steroids can also lead to complication of glaucoma. Okay, so these are the 5 risk factors, and we have discussed the etiology. And you must remember this diagram. This diagram is very important. You must remember this diagram, right? Okay. Now, what is the pathogenesis of primary open angle glaucoma? So increased resistance in trabecular meshwork impedes the aqueous outflow. So if there is an increased resistance, in the trabecular meshwork, that will cause what? That will cause the aqueous outflow blocking. Okay, blockage. Okay, so if there's resistance in trabecular meshwork, it will cause it will not allow the aqueous humor to get drained out. Okay, so it will cause restriction of aqueous outflow. It will cause restriction of aqueous outflow, and due to the restriction of the aqueous outflow, it leads to a gradual increase in IOP, and it damages the retinal ganglion cells. And this increase in IOP leads to the damaging of retinal ganglion cells. Okay, it leads to the retinal ganglion cell damage. And if the retinal ganglion cells are damaged, then progressive optic nerve head cupping and thinning of retinal nerve fiber. So what does this mean? This means that the optic nerve is a head. Okay, so the optic nerve is a head, and the head results in the cupping. So the optic nerve head results in the cupping. Like for example, this is the optic nerve head, and it results in the cupping of the optic nerve. Okay, so it forms a cup-shaped head. Okay, so that is known as cupping of the head and thinning of the retinal nerve fiber layer. Okay, in the retinal layer, the innermost layer of the of our eyeball, this retina. So there are nerve fibers over the retinal layer. So this layer becomes very thin. Why this becomes very thin? Because the retinal ganglion cells in the retina, the retinal ganglion cells are getting damaged. And why does all these things happen? Why all these nerve-related changes are happening? Because of the increase in IOP. Because of the increase in IOP. So you have increased resistance in trabecular meshwork, gradual increase in IOP, which results in damaging the retinal ganglion cells, thinning of the retinal nerve fiber layer, which ultimately result in the optic nerve head cupping or the cupping of the optic nerve head. Okay, it leads to the loss of peripheral vision initially. So initially your peripheral vision is lost, progressing to the central vision. So first your peripheral vision is lost, then your central vision is affected, right? Your first is peripheral vision lost, and the second and the after that, after peripheral vision, your central vision is lost. Okay, so this was about the pathogenesis of POAG. You should remember the aqueous outflow drainage blockage. Okay, sorry, aqueous outflow blockage. Second, increase in IOP, retinal ganglion cell damage, retinal nerve fiber layer thinning, optic nerve head cupping, and peripheral vision is lost initially, later progressing towards the central vision. So this is the pathogenesis of POAG or primary open angle glaucoma. You should write this answer always in a flow chart way. Okay, like first write aqueous outflow blockage, right? And then you should write increase IOP, and then you should write retinal ganglion cell damage. Okay, like this. You should write in a flow chart manner. It looks very impressive to the examiner. Now, what are the clinical features of POAG? So it is often asymptomatic in early stages. Okay, so ophthalmic glaucoma is often asymptomatic in early stages. No symptoms are seen initially. Gradual peripheral vision loss, which is known as tunnel vision. Okay, which is known as tunnel vision. Then optic disc cupping. I told you the optic nerve head undergoes cupping. Then IOP is raised greater than 21 mm Hg. Okay, and defects in visual field, which is arcuate scotoma. Scotoma. Okay, so it is often asymptomatic. First point, gradual peripheral vision loss, which is tunnel vision. And if the central vision is lost, then what does it known as? If central vision is lost, then it is known as scotoma. Sorry, yeah, scotoma. Okay, and if the peripheral vision is lost, then it is known as tunnel vision. The next optic disc cupping, in the optic cup disc ratio is greater than 0.6. Okay, and the IOP is greater than 21. It is not always elevated in glaucoma. It can be such that glaucoma is in the presence of unraised IOP. It is possible. Okay, but most of the times IOP is raised. Defects in visual fields, and we have varieties of visual field defects in glaucoma, but the most common example is the arcuate scotoma. Okay, so just remember this: arcuate scotoma is one of the types of visual field defect in glaucoma. So these are the 5 clinical features of primary open angle glaucoma. Okay, now what are the defects in the primary open angle glaucoma? So these are in the right hand side you can see a diagram. This diagram represents your visual field. Okay, your visual field. So first field defect is a nasal step. Okay, so the nasal step means the black area, this area you can't see. Okay, this area you can't see. Okay, so this is the nasal step, and then you have paracentral scotoma. Okay, I don't think that in this diagram it is given away. This is the paracentral scotoma. This is the paracentral scotoma, and the next is the arcuate scotoma. So this is the arcuate scotoma. Okay, I'll take nasal step, paracentral scotoma, then you have arcuate scotoma, then you have temporal field loss. I think this is the one, temporal field loss, and then you have tunnel vision. So this is the tunnel vision, and temporal field loss is, we don't think here it is, but yeah, it is not given over here. So we don't have temporal field loss. So these are the 4 important, okay, these are the 4 important things. And you should also remember diagrams. This is the first nasal step. This is the second paracentral scotoma. This is the third, arcuate scotoma, and this is the fourth, tunnel vision. In the tunnel vision, you can see only the central part is visible to you. Okay, the central part is visible to you. The peripheral thing is lost. The peripheral thing is lost. Okay, so peripheral vision is lost. That means we are only having the central clear vision. Okay, so that is known as tunnel vision. So in a tunnel, you can only see the center. Rest all the things are covered. Okay, so that is tunnel vision as such as that of a tunnel. Okay, arcuate scotoma, it means arcuate shape. So this is arcuate shaped visual field defect. Okay, and in the in the paracentral scotoma, only a minute part of the center, that is a paracentral region, visual field is lost. And this is the nasal step. Nasal step means just here at the nose. If your this eye is having primary glaucoma, that means you cannot see only this side of the things. Okay, this side of the things. That is the nasal step. Okay, so this is the nasal step. It is related to the nasal visual field. Okay, so you have four kind of visual field defects: nasal step, paracentral scotoma, arcuate scotoma, and progression to the tunnel vision in advanced stages. Okay, and the end stage you will have the complete vision, complete field loss. Okay, complete vision loss. That is at the end stage. Okay, and the temporal field loss is also present. Okay, temporal field loss, but it is not shown in the diagram. That's why I'm not telling you. So just remember these four kinds of visual field defects: nasal step, paracentral scotoma, arcuate scotoma, and the tunnel vision. Okay, these are very important visual field defects. Now, how do you diagnose primary open-angle glaucoma? I told you glaucoma, you can measure it with the help of your intraocular pressure measurement. So, what do you call this measurement as? It is known as tonometry. Tonometry. So, tonometry is done to measure your IOP or your intraocular pressure. Second is gonioscopy. So, gonioscopy measure your open anterior chamber angle. This angle. Okay, this angle. This is the open angle. It is measured with the help of a machine known as the gonioscopy. Okay, gonioscopy measures the open anterior chamber angle. Then third is the optic disc examination, cup disc ratio, and rim thinning. Rim thinning means optic nerve fiber thinning. Sorry, retinal nerve fiber layer. Retinal nerve fiber layer thinning. And curve disc ratio is greater than 0.6. So this is the optic disc examination. Fourth is the visual field testing, Humphrey visual field analyzer. Okay, and in the visual field analyzer, you can see this type of images. Okay, in the visual field analyzer, you can see this type of images. And the next, you can have OCT, which can indicate the retinal nerve fiber layer thickness. Okay, so these are 5 types of diagnosis of POAG. IOP measurement, open anterior chamber angle, tonometry, gonioscopy, optic disc examination, visual field testing, and the retinal nerve fiber layer thickness. Now, how do you manage primary glaucoma? So first of all, we have medical management. In the medical management, we have prostaglandin analogs such as latanoprost. We have beta blockers, timolol. We have carbonic anhydrase inhibitors such as dorzolamide. We have alpha agonist, which is brimonidine. So these are the 4 categories of drugs. We have prostaglandins, we have beta blockers, we have carbonic anhydrase inhibitors, we have alpha agonists. So just remember 1 or 2 examples, or even if you remember one example, it is more than enough. But you have to remember the main category of drugs. Okay. So remember each example. Remember 1 example of each drug. Okay. And then you have laser therapy. In laser therapy, you have argon laser trabeculoplasty. And in the surgical, you have trabeculectomy. Okay, if there is trabecular meshwork resistance, then you can go for trabeculectomy, or you can have minimally invasive glaucoma surgeries. You can have MIGS. Okay, minimally invasive glaucoma surgeries. Laser therapy is also getting more and more important these days because of the use of laser. So argon laser trabeculoplasty is also one mode of treatment, and the most commonly preferred treatment by the patients because of the good compliance is medical management. That is the 4 kinds of drugs: prostaglandins, beta blockers, carbonic anhydrase inhibitors, and alpha agonists. Okay, so that was all about the primary open angle glaucoma. Now we will discuss about the angle closure glaucoma, or you can also say as acute primary angle closure glaucoma. So what is the etiology? The etiology is sudden closure of the anterior chamber angle. Okay, that means your chamber is suddenly closed. Okay, if it was open continuously and if the fault was in the trabecular meshwork, if there's trabecular meshwork resistance which causes the restriction of the aqueous humor outflow, so that was primary open angle glaucoma. What is happening in the angle closure glaucoma is that there is no defect in the trabecular meshwork. There is no resistance in the trabecular meshwork. The thing is that the angle is closed. Okay, I'll show you the diagram. This. Now, this angle is closed. This angle is closed. Okay. Let us draw one diagram over here also. For example, this is cornea. Okay, this is cornea. This was a ciliary body, right? This was ciliary body. And there was a lens. This was your iris. And this was your zone. Okay, so it was like this. So this was the angle, right? This was the angle. Now, if I close this angle, how will I close this angle? If I draw iris, this is a zone, okay. Now this is my iris. This is my iris. This is my zonules, and this is my iris. So there is no angle right now. See, there is no angle. Initially there was angle, but now there is no angle. This is not any angle. Okay, this is not any angle. This is the angle. So there is no angle between the cornea, between the trabecular meshwork, and between the iris. There is no angle between the cornea, trabecular meshwork, and the iris. So the aqueous humor present over here. So the aqueous humor present over here, it has no space to go over here. It has no space to go over here. It has no space, right? So that's why it will lead to the increase in the aqueous humor filled up, and that will result in the increase in IOP. Okay, so the sudden closure of anterior chamber angle or the aqueous outflow blocked by the pupillary block mechanism. Okay, your pupillary block mechanism, it can also cause the angle closure glaucoma. Now, what are the predisposing factors? Hypermetropia. In the primary open angle glaucoma, what was the risk factor? It was myopia, but now here the risk factor is hypermetropia. So etiology, predisposing risk factors. Okay. Now hypermetropia, shallow anterior chamber. Okay, age greater than 50 years, female gender, and positive family history. So positive family history was there also, age was there also. Now three things are new here. There it was myopia, here it is hypermetropia. Here it is shallow anterior chamber and female gender. There was African or Asian ethnicity. Okay. So you have to remember the etiology and the predisposing or risk factors of the angle closure glaucoma. Now, what are the clinical features of the angle closure glaucoma? There is severe ocular pain and headache. Severe ocular pain and headache, which was not present in the primary open angle glaucoma. Rather, it was asymptomatic. But angle closure glaucoma is not asymptomatic. It presents with severe ocular pain and headache. There can be blurred vision with halos around the lights. There can be nausea and vomiting. There can be red eye with mild dilated or fixed pupil. Okay, mid dilated and fixed pupil. There can be corneal edema, and the IOP is greater than 40. In the primary open angle glaucoma, the IOP was greater than 21 mmHg, but here it is greater than 40 mmHg. Such a huge difference. Okay, so just remember the difference between. Just also notice the difference between the angle closure glaucoma and the primary open angle glaucoma. So these are the clinical features: ocular pain with headache, blurred vision with halos around the lights. They can nausea and vomiting with angle closure glaucoma. They can be red eye with the mid dilated and fixed pupil. The pupil is very fixed and it does not change. Okay, the pupil does not constrict, neither it dilates. There is a fixed pupil. Okay, no matter how much light do you put, or how much dark light or how much bright light you put into the patient's eye, the pupil is fixed. It does not constrict, neither does it contract. Okay, sorry, neither does it dilate. There can be corneal edema, and the IOP is raised above 40, which is a great number. Okay. So what is the management of angle closure glaucoma? So medical management. Okay, medical management includes hyperosmotic agents, mannitol. Okay, you can give the mannitol. Second, carbonic anhydrase inhibitors like acetazolamide. Okay, we were also giving carbonic anhydrase inhibitor in the primary open glaucoma as well. Topical beta blockers and alpha agonist like that of uh, primary open glaucoma. Okay, we can also give miotics like Pilocart. So these are the two new drugs in addition to the primary open glaucoma. Rest is safe, like carbonic anhydrase inhibitors, acetazolamide, and topical beta blockers and alpha agonists. Now you can also do a laser surgery, which is a laser peripheral iridotomy. Okay, so you are making a cut in the iris. Iridotomy means you're making a cut in the iris such that the aqueous humor gets a path to flow towards the trabecular meshwork. Okay, so it is known as laser peripheral iridotomy. It is a definitive treatment. Okay, it's a definitive treatment, and you can also do surgical iridectomy. Iridectomy means you're taking out whole of the iris. You're taking out whole of the iris of the patient. Okay, so that is surgical iridectomy, and this is done if the laser fails or it is not feasible by the patient. Okay, so these are the medical, laser, and surgical management of the angle closure glaucoma. What is the mechanism of primary and secondary angle closure glaucoma? So in the primary, you can have pupillary block causing obstruction of aqueous outflow from posterior to the anterior chamber, or you can also have iris pushed forward, closing the angle. So these are the two mechanisms. Okay, you can have the pupil block, or you can have iris pushed towards the cornea. In the secondary mechanism, you can have conditions like uveitis, neovascularization, or trauma. Okay, so you can have due to uveitis, due to the neovascularization, or due to the trauma. There can be secondary angle closure glaucoma. You can have peripheral anterior synecdoche or mechanical obstructions. So you just have to remember these causes for the secondary angle closure glaucoma: uveitis, neovascularization, trauma, peripheral anterior synecdoche, and mechanical obstruction. So just remember these as 5 causes which are responsible for causing secondary angle closure glaucoma. Now, this was about the angle closure glaucoma. Now we will be discussing about ophthalmos. What is ophthalmos? Ophthalmos is a congenital or infantile glaucoma. Okay, glaucoma in the neonatal infants. So it is what are the clinical features of ophthalmos? So there's an enlarged cornea and globe. So the eyeball as a whole is enlarged, and there's an enlarged cornea. You can see in this child's eyes. Okay, the cornea is very enlarged, and it is occupying most of the part of your eyeball. Okay, the cornea is enlarged, and the eyeball is also, or the globe is also enlarged. There can be photophobia, tearing, and blepharospasm. Okay, there can be photophobia and tearing of the eye and blepharospasm. There can be corneal edema and the HAPS striae. Okay, HAPS striae is one lining over this cornea. Okay, this lining over this cornea. It is not visible in this child's eye, but it is visible in some of the children. You can have elevated IOP, optic nerve cupping. Okay, so these are the 5 clinical features of this ophthalmos. You can have enlarged cornea and globe. You can have photophobia, tearing, or the blepharospasm. You can have corneal edema. You can have HAPS striae. You can have elevated IOP and optic nerve cupping. Okay, so these are the clinical features for the ophthalmos. And how do you manage this condition, ophthalmos? To control the IOP initially by giving acetazolamide. Okay, because in children you cannot give beta blockers and many other drugs like we used to give in the primary glaucoma. In the children, the drug has to be given very cautiously. So we are giving the acetazolamide in calculated dosage. Okay, and surgically you can manage this condition by goniotomy and trabeculectomy. Okay, goniotomy, trabeculectomy, and you can also do trabeculectomy with adjunctive mitomycin C. We will discuss what is mitomycin C. So these are the surgical medical management option for ophthalmos. It is not very common, unlike that of adult or primary open angle glaucoma or angle closure glaucoma. It is not common in children, but it is seen sometimes where you have the family predisposition towards the glaucoma. Okay, so we have discussed clinical features. We have discussed the management of the ophthalmos. Now, what is acute congestive glaucoma or acute angle? This is acute angle closure glaucoma. What is acute congestive glaucoma? acute congestive glaucoma, it means you have congestion in your eyeball. You have congestion in your eyeball. So we will see what are the clinical features of acute congestive glaucoma. You can have sudden onset severe pain and vision loss, halos around the lights, vomiting and headache, red eye, corneal edema, and mild dilated pupil. So it is more or less same just as that of acute angle closure glaucoma. Okay, acute angle closure glaucoma or acute congestive glaucoma is one or more the same. Okay, management is same: laser peripheral iotomy, hyperosmotics, and anti-glaucoma medications. Differential diagnosis is acute anti-uveitis, scleritis, and conjunctivitis. Okay, so this is not something very new we are learning. This is just as same as that of acute angle closure glaucoma. You can see in the right hand side the diagram of the acute angle closure glaucoma. Okay, so this is the acute congestive glaucoma, acute angle closure glaucoma. Now we will discuss about what is pseudo exfoliation syndrome. So pseudo exfoliation syndrome is a deposition of whitish material on the lens. Okay, so you can see over here whitish material deposited on the lens. Whitish material deposited on the lens, or this, sorry, this is the whitish material deposited on the lens and the trabecular meshwork So whitish material deposited on the lens capsule and the trabecular meshwork. There is weak zonules predisposing to the lens subluxation. Okay, weak zonules means this is your cornea. This is your lens. This is your zonules and this is your iris. Okay. So these zonules have become weakened. If these zonules are weak, what will happen? The lens will not be in place. The lens will not be in place, and there's a risk of lens subluxation. Subluxation means moving out from its own place, or it is displacing from its own place. Okay, so that is lens subluxation. And there can also be deposition of whitish material on the lens capsule, and the trabecular meshwork. So there can be deposition of the whitish material in the lens capsule and the trabecular meshwork. And the third point is open angle glaucoma due to the trabecular meshwork damage. Okay, so the pseudo exfoliation syndrome or glaucoma, it is the same as open angle glaucoma. It is just known as a pseudo exfoliation syndrome. Okay, the meaning of these words, okay, the words are different, but the meaning is one or more the same. So if you get a question of pseudo exfoliation syndrome as a long question or as a short question, you have to write about the primary open angle glaucoma completely. In addition to that, just write these 2 points. Just write these 2 points in addition to the primary open angle glaucoma. It will give you the maximum mark. It will give you almost a full marks for that question. Okay, so you will write deposition of whitish material on the lens capsule and trabecular meshwork. You will write the weak zonules present, which leads to the lens subluxation, or which predisposes the lens towards the subluxation. And you will explain, and you will draw a diagram like this, which explains the subluxation of the lens. And you will also describe about the open angle glaucoma as you have discussed it earlier. Okay, now what is iridectomy? Iridectomy means you are taking out the lens. You are taking out the, you're taking out the iris. You're taking out the iris. Okay, so if you want to take out the iris, okay, so if you're getting a question of iridectomy and you want to draw a diagram, so what diagram you will draw? You will draw same diagram like this. Okay, this is the lens. Just draw zonules. Then this is the iris. Then this is the cornea. Then this is the iris, zonules, and again this. So just draw. This is the part that we are removing. This is the iris part that we are removing. Okay. Now, why we are removing this iris? What are the indications for remove? What are the indications for doing iridectomy? So our indications are acute primary angle closure glaucoma, secondary angle closure glaucoma due to pupillary block, and third is preventive in high-risk fellow eyes. Like if you have a family predisposition, if you are family predisposed towards the angle closure glaucoma, if your parents are having, if your grandparents are having, then you should get iridectomy for prophylactic management. Okay, so these are the indications for doing iridectomy. Complications, there can be hyphema, iris prolapse, IOP spikes, secondary glaucoma. Hyphema means collection of blood in the anterior chamber. Iris prolapse means your iris can get prolapsed into your cornea, or it can come out of your eyes. Okay, IOP spikes means IOP can further raised or further increase more than its original value. There can be secondary glaucoma due to the cutting of the iris or taking out of the iris. Okay, so these are the complications that can result as a complication of iridectomy. Okay, so these are the indications and complications of iridectomy. Now these are two again short questions which you can get in your exams, like how is aqueous humor formed and what are the uses of mitomycin C in our eyes. Okay, so how is aqueous humor formed? It is produced by ciliary body epithelium. It is produced by the ciliary body epithelium. Now, what is ciliary body epithelium? What is ciliary body? This complete structure is a ciliary body. This complete structure, which I'm highlighting it. Okay, okay, this complete structure is a ciliary body. So it has a epithelium like this. Okay, so it has an epithelium like this. Now this epithelium produces aqueous humor and secretes into the anterior chamber. Okay, so this epithelium produces the aqueous humor and secretes into the anterior chamber. Now how does it get secreted? Mechanism is diffusion, ultrafiltration, active secretion. These are the three terms that you need to remember. Diffusion, ultrafiltration, and active secretion is a mechanism by which aqueous humor is secreted from the ciliary body to the anterior chamber, right? From the ciliary body to the anterior chamber by diffusion, ultrafiltration, and active secretion. And it drains by the trabecular meshwork we have read and Schlemm's canal. Okay, Schlemm's canal is present in the trabecular meshwork only. So just remember these two terms, Schlemm's canal and the trabecular meshwork, it drains. Now, what are the uses of mitomycin C in our eyes? So it is used as an adjunct in trabeculectomy to prevent scarring. Okay, so if you are doing surgical treatment in glaucoma, such as trabeculectomy, so it leaves a scar in your eyes. Okay, so if you want to prevent scarring, then you should use mitomycin C as in addition to the trabeculectomy. Okay, so mitomycin C is also used in the pterygium surgery to reduce the recurrence of the pterygium, because pterygium is a very recurrent condition, and even after surgery, even if the small amount of pterygium is left, it can lead to the recurrence of pterygium, and it can also used in the corneal refractive surgery such as PRK. Okay, in such as radical keratectomy. Okay, a radical keratectomy it can be used in, and trabeculectomy and pterygium surgery. So this was about the total glaucoma. It is a very important topic, and it is a very concise topic. Only the 2 or 3 main concepts are there around which the whole topic goes around. Okay, so 2 to 3 topics, 2 to 3 things that you should learn, like what is ciliary body, what is iris, where are zonules, how does it place, what is an angle, right? And you should remember at least one diagram. This diagram is common to every answer. Okay, this diagram is common to every answer. So this diagram you must know. You can draw it in every answer, and you should know the terms of the meaning. So you should know the meaning of the terms like pseudo exfoliation syndrome, okay, acute congestive glaucoma, ophthalmos. So these are the terms that you should be aware of, and it is not a new topic or new thing that we have learned. Okay, so these are related to the open-angle glaucoma and annual glaucoma only. So we have learned about the glaucoma. What is the complication? What are the management? What are the clinical features? What are the etiology, predisposing factors, diagrams? Okay, we have learned almost everything about glaucoma, which can be asked in your exams, and you should know. By now, you should know that under which points you have to write your answers and how to frame your answers. And I told you that this diagram will suffice in almost every answer. Okay, you have to draw at least 1 to 2 diagrams in every answer. Okay, so just draw this diagram and it will fetch you maximum marks. Okay, so that's all for today. Okay, thank you for watching, and we'll meet again in our next live class. Thank you very much. Hello.
Yes, sir.
Okay, thank you. I finished.
Thank you, sir.
Okay, thank you.